Piracetam is the original prototype of the nootropic class. It presents an immediate chemical contradiction. Its molecular structure is derived directly from the inhibitory neurotransmitter GABA, yet it possesses zero GABAergic pharmacological activity. This side-by-side diagram illustrates why its mechanism defies standard psychopharmacology. Instead of docking into specific receptor sites like a classical lock and key ligand, piracetam acts as a diffuse neurophysiological stabilizer. This mechanical divergence creates a stark split between the drug's popular reputation and its clinical reality. While widely known as a cognitive enhancer, it is primarily effective at treating cortical myoclonus and central vertigo, with a near-total absence of robust evidence for cognitive improvement in healthy individuals. Pharmacologically, it is formally classified as a nootropic agent. It serves as the foundational prototype for the entire racetam class of drugs. When a neuroactive compound bypasses specific neurotransmitter receptors entirely, it demands a different mechanical model for cognitive enhancement. Researchers had to look completely past standard synaptic signaling and deeply examine the physical properties of the neuron itself. This timeline traces the historical trajectory of the drug, beginning with its synthesis in 1964 by the Romanian chemist Cornelius E. Georgia, who explicitly coined the term nootropic in 1972. Widespread European adoption in the 70s and 80s sharply declined by the 1990s, when early observational success failed against the rigorous demands of modern randomized controlled trials. However, as clinical medicine abandoned the drug, it saw a massive resurgence in popular culture, becoming an off-label staple in emerging biohacking and self-optimization communities. The arc of piracetam illustrates a recurring tension in psychopharmacology, the gap between a compelling, biologically plausible mechanism of action and the harsh requirements of evidence-based clinical proof. To understand what piracetam actually does, we have to bypass neurotransmitters entirely and look at the subcellular bedrock of the brain. Operating at the cellular boundary, piracetam molecules insert into the phospholipid bilayer, mechanically increasing lipid tail validity. This highly compliant environment allows transmembrane receptors to change shape easily, increases ion channel efficiency, and accelerates the fusion of synaptic vesicles with the cell membrane. The neurobiological implication is a vast improvement in signal transduction efficiency. This physical stabilization is particularly protective when neurons are under the stress of hypoxia or normal age-related structural decline. Beyond the membrane, the drug exerts a glutamatergic modulation effect. It acts as a positive modulator for AMPA receptors, directly increasing the excitatory throughput of the neuron. This AMPA modulation subsequently creates an indirect facilitation of NMDA receptor function. By optimizing both AMPA and NMDA dynamics, the drug heavily favors the induction of long-term potentiation, the primary cellular mechanism driving learning and memory encoding. Concurrently, piracetam activates a cholinergic enhancement pathway by drastically increasing high-affinity choline uptake. The increased choline uptake directly facilitates a higher volume of acetylcholine release in the hippocampus. This specific pathway explains its early, targeted use in mitigating Alzheimer-type cognitive dysfunction and general age-related memory decline. At the metabolic level, the drug initiates a cascade of neuroprotective effects. It enhances total ATP turnover, increases cellular oxygen utilization, and reduces free radical damage. Taken together, these diffuse subcellular modifications act as a universal signal-to-noise optimizer. Piracetam does not force a localized, specific stimulation. It ensures the existing neurological hardware runs with less physical friction. Moving from the single neuron up to the broader vascular system, the drug exhibits highly distinct hemorheological properties. Piracetam interacts with the membranes of red blood cells, physically improving their deformability.
Simultaneously, it actively reduces platelet aggregation. By making red blood cells more flexible and preventing platelets from clumping, the drug yields a systemic decrease in overall blood viscosity. These hemorheological changes significantly improve cerebral microcirculation. Crucially, it achieves this enhanced blood flow entirely without inducing vasodilation. Mapping these mechanisms to macro brain architecture reveals specific patterns. In the hippocampus, increased long-term potentiation drives memory encoding. Across the cortex, improved membrane fluidity increases raw signal propagation efficiency. In the cerebellum, this physiological stabilization mitigates misfiring networks, reducing cortical myoclonus. This table outlines the pharmacokinetic profile. Absorption is nearly complete, achieving peak plasma concentration in 30 to 60 minutes. It binds minimally to proteins, undergoes zero hepatic metabolism, and is excreted unchanged via the kidneys. The 4 to 5 hour half-life increases in the elderly. A drug with universal membrane affinity and zero liver metabolism is highly efficient for systemic neuroprotection. However, because it relies entirely on the kidneys for clearance, the system is highly vulnerable to renal failure. There is a severe disconnect between piracetam's broad mechanical promise and what the clinical literature actually proves. This 4-tier pyramid stratifies clinical data. The top established tier strictly supports cortical myoclonus and central vertigo. Moderate evidence shows limited post-stroke benefits. A third tier holds weak evidence for Alzheimer's and dyslexia. The lowest tier, healthy cognitive enhancement, has exceptionally poor clinical data. Comparing piracetam to modern alternatives, modafinil relies on a targeted dopamine mechanism, producing moderate cognitive effects with stronger clinical evidence, but lacks piracetam's neuroprotective qualities. Donepezil operates via specific acetylcholinesterase inhibition, providing strong, disease-specific evidence for Alzheimer's management, far exceeding piracetam's weak efficacy. Piracetam's diffuse mechanism makes it an excellent low-toxicity neuromuscular stabilizer, but that same lack of receptor specificity inherently limits its ability to rival highly targeted drugs for specific cognitive diseases. Because of its low toxicity, dosing parameters vary drastically by condition. Standard cognitive disorders utilize 2.4 to 4.8 grams per day, whereas treating severe myoclonus can require massive doses up to 24 grams daily. At these high dosages, side effects emerge. The most common are nervousness, insomnia, weight gain, and headache. In elderly patients, the stimulating effect on a fragile CNS can occasionally induce severe agitation or confusion. The primary hematological risk stems directly from its intended mechanism. Because the drug strongly inhibits platelet aggregation, patients experience an increased bleeding tendency. This creates absolute contraindications. Piracetam cannot be used in patients with severe renal impairment, active bleeding disorders, or hemorrhagic stroke. Crucially, it creates severe drug interactions by dangerously potentiating anticoagulants like warfarin. Due to limited systemic data, it is generally avoided entirely during pregnancy. For any patient with mild to moderate renal impairment, aggressive dose reduction is mandatory to prevent toxicity. A critical appraisal of the clinical literature reveals fatal methodological flaws in the drug's supporting research. The vast majority of positive trials rely on highly inadequate sample sizes, poor blinding protocols, and extremely heterogeneous clinical endpoints. While broad meta-analyses do show a modest overall benefit in generalized cognitive impairment, the high heterogeneity of the data prevents these findings from translating into robust, reliable clinical practice. Piracetam remains a profound, non-receptor neurophysiological stabilizer with strict clinical niches. It proves that mechanically optimizing the brain's cellular hardware does not guarantee an automated upgrade to its cognitive software.